Hello, everybody, and welcome to Spine Time. My name is Roger Härtl. I'm the neurosurgical director of spine at Weill Cornell Medicine here in New York City, and one of the co-directors of the Center for Comprehensive Spine Care. It's my great pleasure to welcome you back to Spine Time. This is the special service that we offer to our patients and anyone else who's interested. We talk about any topic that's relevant for spine, for patients who suffer from spinal problems. And it's my great pleasure today to welcome some of the experts here at the Spine Center to talk about cervical neck-related spine problems, pain in the neck. And who hasn't experienced pain in the neck, of course? That's a very relevant topic for all of us. So we have a number of great people at the Spine Center, of course, in addition to today's faculty. As you know, at the Spine Center at Weill Cornell, we take care of all spine problems from diagnosis to treatment to recovery. We work with experts in pain management, rehabilitation medicine, neurology, surgery, orthopedic and neurosurgical spine surgery. And we work very closely with complementary medicine and all the other subspecialties at Cornell and Ox Spine to be able to really cover all your needs that you may have as a patient. And we're very proud of the service that we've been able to provide to you and the community for many years now. Now today we have two top people who's going to talk about cervical problems. Dr. Vincent Miccio, who's an assistant attending physician and assistant professor of clinical rehabilitation medicine at Weill Cornell Medicine here in New York. He sees patients at the Spine Center and also at Methodist Hospital. And then we were supposed to have, and in your emails it said Dr. Daniel Pack, but he can't be here because his wife actually had a baby last night. So he's excused. He's doing great. The baby is doing great. Congratulations, Dr. Pack. And we have, however, almost better, Dr. Neel Mehta, who's the head of pain management at the Spine Center here, who you all know, of course, from previous webinars, and I'm sure many of you have probably seen him also in clinic here. He's associate professor of clinical anesthesiology. He's an associate attending anesthesiologist at Weill Cornell Medicine and one of the co-directors of the Center for Comprehensive Spine Care. Now, we've got a lot of territory to cover, pain in the neck. We'll get started. We'll have Dr. Miccio maybe walk us through a little bit of anatomy so everybody is on board. While we're doing that, please remember we have a chat box and you're welcome to submit comments, questions, concerns. We'll try to pick those up and we'll try to address as many of those as possible. It's not always possible to cover everything, but we'll try our best. So let's learn a little bit about neck anatomy, Dr. Miccio. And thanks for being here.
Thank you very much for the invitation to come speak to you all today. It's a pleasure. So first of all, when we start talking about the neck, we're actually talking about the cervical spine. And so you can see on the diagram here, it's this upper portion that we are looking at. That's the upper portion, which is right above the thoracic spine, above the lumbar spine, the sacrum, and the coccyx. As we take a look closer at the cervical spine, we see it pictured here on if we progress to the next slide there. Yeah, so we see it from the back on the left-hand side there, and we see it from the side on the right-hand side here. Cervical spine is made up of 7 vertebrae. These are labeled C1 through C7 here. The discs are labeled according to the adjacent bones. So that is the C2, that's C3, 4. We see C4, 5, C5, 6, C6, C7. The discs between the vertebrae are not the only points of contact between the vertebrae. In addition to the discs, there are these small joints on either side of the back of the spine called the facet joints, We can see that in the diagram on the right-hand side here. These are joints. These are just like knees, hips, shoulders. They have a capsule. They have capsular ligaments. And this also means that they can become degenerated and that they can be subject to osteoarthritis. Moving along here, we also see that there are a number of ligaments involved here. On the left-hand side, you can see these ligaments looking from the side. And then on the right-hand side here, we see a diagram depicting things looking from the back and at an angle here. You can see all of this interplay of these different ligaments that provide structure to our cervical spine. And, you know, neck pain is so pervasive that we all experience it. And so this is definitely something that we all live with, and to a lot of folks, it is a bit of a black box, you know, and that's probably the most concerning thing sometimes about back pain, about neck pain, is that sometimes for some patients, the anxiety involved with sort of not knowing what's going on with your spine can be quite distressing, as we see in the next slide here. You know, this simply not knowing what's going on can cause quite a bit of distress. That's why we're here, is to sort of educate you a bit and give you some insight into what might be at play.
Dr. Miccio, thank you. You walked us through the anatomy. But now it's time to test Dr. Mehta a little bit, because he wasn't here during the preparation, and we put some slides in here to test his medical knowledge. You know, giraffes, right? You see the picture, everybody. Now, how many, we learned that humans have 7 vertebral bodies, right? In the cervical spine. Dr. Mehta, how many vertebral bodies does the giraffe have?
Well, that is a great question, and I often ask my neurosurgery friends to help me out with the answers for this, because we're a team approach here at the Center for Comprehensive Spine Care. I'm going to venture a guess at 20.
Yeah, close. No, it's actually 7, believe it or not.
Oh boy, well,
they're just very big.
Slightly
they're just
over.
very big. And then it says here, so much on my mind, it's a wonder my neck doesn't snap. So what about, you know, Dr. Miccio, and we'll talk more about the anatomy, but what about psychology? Is that important? I mean, a lot of pain in the neck, we say that for many, many different reasons. And what in your experience, how often is that really related to people having such a hard time, or with COVID now, or you know, family divorce, or any other kind of psychological thing that's going on?
Yeah, it's a very good question. You know, I actually find that patients come to me with almost like the opposite situation, where they come to me and they say, is it all in my head? You know, and they say, am I making this up? And sometimes I have to reassure patients that, you know, I think that they have real pain, that there is something real going on in their neck, and they don't have to blame themselves for the fact that they likely have some sort of abnormal pathology going on that's causing their pain. And then we talk about how stress, about overuse, overwork, it just takes that pain and it turns up the volume. So I think people are used to thinking in kind of like a black and white situation, that either you are sort of making something up or not. But the reality is that everything is related. Our mood, our relationships, our sleep patterns, our nutrition, it's all related, such that if any of that stuff is out of whack, then your pain is kind of, like I said, the volume of that pain is certainly turned up. And as it relates to what I was saying before as well, the more educated you can be about what is going on, the less anxiety that comes into the picture, and patients can be quite relieved by education itself.
Right. Well, and even giraffes can have neck pain, as you can see. They actually.
Please don't ask me another giraffe question.
Yeah, Neel Mehta, another question. Why isn't Dracula invited to parties?
Why?
Because he's a pain in the neck.
Oh.
All right. Now let's go back to medicine. So, Dr. Miccio, joints, discs, muscle, nerves.
Yeah, I mean, all of these can be pain generators in the neck, and that is what our goal is. Our goal is to find the pain generator, to try and use the interview, to try and ask you the appropriate questions to get down, to be a detective about it, and really try to figure out what is causing your pain. And each of these different structures in the back and the neck causes sort of a different pattern. To the right here, you see some patterns that discs can cause. On the left-hand side, the upper left there, you see some referral patterns from some of those facet joints that I spoke about. Muscles on the lower left corner, hand corner there, they can refer pain quite a bit, as in the case of trigger points. And then, of course, with nerves, if one has nerve impingement, it can refer to the extremities. But if it's an upper cervical issue, sometimes it can stay around the neck and stay within the shoulders.
Now, let me ask you, that's really interesting. So if somebody comes and sees you in the office, Neel or Vincent, and let's say they have pain in the upper part or in the lateral aspect of the neck. Now, if you look at, if you examine the patient and you don't look at the films, you don't know much about, so this could be really coming from, let's say they have pain here. So this could be coming from the joint. This could also be coming from the muscle, the pain, or it could be coming from nerve compression, right? So how do you figure out where it's actually coming from? Maybe we'll have Neel, other than asking him, stupid quiz questions, we'll ask him a real medical question. So
Yeah,
how can you figure that out?
Next time I'm going to have Dr. Pak answer those questions. But I would say that, it's as with anything, we're going to look at the history of how they're presenting. So if you notice in the nerve area, a lot of it is radiating much further down into the arms. Now, some of the higher up areas could present in the neck. We see that overlap, but those aren't the typical areas of cervical problems. I'd say that the majority of disc herniations tend to be a little bit lower down in the neck. The next part is we look at what is the nature of their pain? Is it confined into certain areas? Is it more positional? Is it when they rotate their head? So we're using physical exam. We're looking for particularly tender areas that may allude more towards muscle versus joints. And then partly is the ability to use our diagnostic tests, MRIs, X-rays, CAT scans if needed. And even some of the procedures that we're going to talk about can be equally diagnostic and therapeutic. So we use the feedback of how the procedure went and the result to help us pinpoint, are we on the right track for treatment? And that's finally, as we talk about in every one of these spine times, is that the power of our center is the ability to discuss as a group, coming at it from different experiences and expertises. So we just finished half an hour ago discussion of cases like this with our radiology colleagues, neurologists, pain specialists, surgeons, and even some of our psychologists and physical therapists. So we, sometimes if we're confused, we do involve more folks with expertise.
Yeah, that's a good point. And I think you can also inject, right? You could inject, you do a nerve block to see if it's coming from the nerve or facet, joint block, and you can, it's like a puzzle. It's like a detective story, right? You kind of go through all these to figure out.
That's correct.
Now, I think Dr. Miccio want to talk about this upper cross syndrome. What is that?
Yeah, so, I just wanted to take the opportunity to highlight one of these very typical muscular imbalances that we see, especially in today's age, where, as you can see in the left-hand corner, there's the depiction of, some folks who could be any of us, either using our cell phone or hunched over a computer screen. And both of the individuals on the left-hand side of the screen here are susceptible to develop this upper cross syndrome. This is actually a pattern of muscular imbalance that was identified in the 1970s. Nowadays, we call it tech neck or text neck. And what you see here is you see this pattern that if you were to draw an X along the front and back of the spine here, you see this pattern of some muscles being weak, especially the deep cervical flexors, and in the back, the lower trapezius and the serratus anterior. And that's paired with tightness on the other limb of the X here, where the trapezius muscles get extraordinarily tight and the pectoralis muscles get tight. This moves the shoulders forward and leads to a lot of neck pain, headaches that can be associated with, putting in long hours in front of a computer or studying a long time. So, my primary training is in rehabilitation, and we focus a lot on these kind of muscular patterns, these sort of maladaptive patterns and such. And this is one of them, just to highlight one typical thing that we see over and over again.
I think related to this has been, how people have their hygiene when they're going to sleep. A lot of people are reading in bed, using their phones in bed. Definitely. And I think that's equally important. I agree completely with Vince.
Yeah.
And there's a related question in the chat box about whether neck issues can cause headaches. And absolutely, we believe that something in the differential when trying to figure out causes of headaches.
Oh, so let's go a little bit more into treatment. Before we have this quote here: "I'd rather have roses on my table than diamonds on my neck." That brings me to a question. We frequently have patients that we treat with collars, right? Cervical collars, sometimes after surgery to just help them heal. But some patients wear collars for neck pain, for example. What are your thoughts about that?
Yeah, I mean, the general principle is to get the muscles of the neck to do their job and to stabilize the neck themselves, right? So that your best stabilizers are your own neck muscles. However, if you've had an acute injury or if you've had a surgery, sometimes those muscles can be inhibited, and so they don't perform the job that they need to. And that's where physical therapy can come into play, where there's sort of this transition between that, from that acute injury or post-operative course to having a normal amount of stability in the neck and strength in the neck that a brace can be helpful. I don't regularly recommend neck braces to my patients simply because, like I said, I don't want their muscles to become more weak. I want them to become stronger. However, for patients that do have significant pain with more rigorous exercise, sometimes I'll recommend wearing a brace for a short period of time while they exercise to sort of offer as a transition period to removing that brace.
While they exercise, you mean during the exercises or?
During therapy, yeah, during physical therapy.
Yeah. Neel, any thoughts about other bracing in your practice?
Yeah, I agree with Vince in that it can be supportive. There are definitely times where people find comfort in wearing it, especially, obviously the soft collars, but you don't want it to make it a chronic usage if you can avoid it. Your goal is to really use your own body to try to support things as much as you can. It's the same concept in back pain and the use of back braces.
Yeah, and we do the same after surgery. I mean, the cervical collar, in some of the longest surgeries that we do, we have patients wear collars for usually 6 weeks during the day just to maximize the chances of everything healing up. Or if somebody has problems with osteoporosis or other concerns about the fusion surgery not healing up, we have them wear a collar. But we don't want to do it for more than that because the muscle is obviously very, very important. And we've talked about this in this context many times with Norman Marcus, with Neel, with others, with Ricky, the importance of the muscle really to, at the end of the day, to support the neck and prevent pain from coming up. Now, Vince, you mentioned this briefly before, the text neck, right? Maybe since this is so prevalent, right? And you walk outside, everybody's looking at their phone. Not only is that an incredible risk when when you're walking on the street for obvious reasons, but it also causes pain. Any more comments about that?
Yeah, when we see patients, we see patients along the whole spectrum of injury, from acute injuries, where the management is quite different of an acute injury from a more chronic injury. In this case, what we're trying to do is we're trying to institute preventative measures to actually prevent the onset of neck pain. And a lot of this stuff is rather common sense, as this diagram shows here. Holding your device such that your neck is in an optimal position, taking frequent breaks and such. I think it really does help, especially when it comes to disc pain, whether in the neck or the lower back. I didn't coin this term, but a favorite term of mine or saying of mine is the best posture that you can have is the next one. Meaning that, if you spend all day long working at your computer in one position, your body will not be happy with you. So as humans, we're designed to move. We're designed to be dynamic, and our bodies like that. But in modern times here, often we're too static. So I really agree with steps number 2 and 3, especially.
Yeah, I got to tell you, we do so many Zoom calls, and when I'm at home on a Zoom call, either with patients, with colleagues, conferences, it's really bad to sit on a table and do this. So what I do is I force myself to get up. I bought one of those little standing desks. So I go back and forth. I do one Zoom call sitting down, the other one standing up. And it's crazy that we have to do that, but it makes a big difference.
And I think that's the right way to do it. I have some patients that tell me they have a standing desk, and I say, well, do you use it? And they say, yes, I stand up all day. And so that's also defeating the purpose, right? The purpose is to actually move, to actually use that, to modify your position.
So we have a bunch of questions about cracking the neck and about massage. I think we actually have that here. So some patients tell me, if I move my neck like this, it cracks. I get better. I get very nervous when I see this, especially, sometimes, especially if you've seen the patient's MRI scan beforehand and they have spinal cord compression. And now they tell you, if I crack my neck, I feel better. Let's talk about manipulation, either yourself or, chiropractors, the benefits, the risks. First of all, the cracking, where does the cracking sound come from? Does anybody know?
I've heard a few different explanations, and I'm curious what Vince will answer. But my understanding is that a lot of it is just air, sort of in the joints that's being released, and that there's no real physiologic danger in cracking, but in the sense that anything that becomes habitual, wear and tear can occur. I'm curious what your take is on it, Vince.
Sure. In research that I've done on this is that there essentially is a bubble within the synovial fluid, within the the joint fluid, that implodes as you crack the joint. Usually it's carbon dioxide or nitrogen that is within this bubble. There are some studies that we can extrapolate data from this. There's a well-known study where a physician decided to crack the knuckles of his left hand for a year, and it was longer than a year. I think it was something like 5 years, and he did not crack the knuckles of his right hand. And they found that there's no difference in the development of osteoarthritis of the hand that he cracked. And so I think that there is, how do I say, I think the answer, as usual, is somewhere in between here, where you have to use common sense to a certain extent. However, there does not seem to be a very clear relationship between the amount of times that you crack your neck or the frequency with which you crack your neck and the development of arthritis. However, as Dr. Mehta stated, if you do something over and over and over again enough, it is likely to cause an imbalance or an irritation. So I think moderation is usually the name of the game here.
What about neck manipulation? Let's say you have neck pain, you see a chiropractor. I just say chiropractor, but could be any therapist, I guess. Any concerns? What should patients take into consideration when they go that route?
You know, my initial feeling about it is that number one, a lot of the patients that we see, I mean, we see patients of all types, all ages, but a lot of the patients I see come to me with pretty significant pathology of the cervical spine. It is not uncommon to see a patient come to me who had been recommended to have surgery, and they're questioning it, they're looking for another look and such. And in those patients, like as Dr. Härtl mentioned, I'm very nervous about them having aggressive neck manipulation. And the issue is that I think it's an issue of standardization. If I refer a patient, or if I have a patient who's going to seek care with a chiropractor, I kind of don't know what they're going to get. They might get an adjustment with a small gun that applies a very little bit of pressure, or they might get a high velocity, low amplitude adjustment, which is serious of the neck. So that lack of standardization makes it a little bit hard for me to recommend that.
Neel, any experience with traction, those traction devices? When do they work, when not?
Yeah, I mean, I think traction in good physical therapy, even home-based traction, often is helpful for things like disc herniations. And it does relieve some of the tension on the disc. But with anything, it's with proper guidance and sort of demonstration of how to use it. And to go back to some of the things about cracking and manipulation, a lot of it is, if you look at this particular picture where the gentleman's trying to crack his neck, a lot of it is just stretching of these muscles that are involved in chronic neck pain as well. So it's always something, you may think you're treating one thing, but you're actually, the maneuver or the treatment is actually working towards something else. So yeah, I think traction in the right context can be helpful.
Yeah, in my experience, patients who have, nerve compression, sometimes it's transient, from a herniated disc, and the traction can actually help decompress that a little bit. As long as they don't have a neurological deficit, I think it's not unreasonable if it's done carefully. With chiropractic manipulation, I always tell patients to be careful because definitely make sure you know what the MRI scan looks fine and it's probably okay, but I've seen patients have vascular injuries, spinal, disc herniations, all types of things from manipulation done probably not properly and not carefully. So I think the patients that we see, most of them have pathology, so you got to be really, really careful when you undergo manipulation. Let's move on. Whiplash, right? Something we see a lot, especially in the city. You take a cab, and you get into a situation where the car stops and your head is being, moved. You go forward, backwards. You have a whiplash injury. Any thoughts about that? When should one be concerned? How do we typically treat that, and what's the prognosis? Maybe Neel.
Yeah, so whiplash is one of the major concerns is obviously something structural underneath, and that's when we look for our neurologic exam, and we get you involved in terms of if there's a risk of injury to the spinal cord and making sure that there isn't something surgical that has to be done. But in the absence of that, it tends to be more muscular pain in nature, and we really just working through healing and pain relief until it resolves. And a lot of the muscles that are involved in whiplash injury can be overlapped into headache type and neck pain related symptoms. So it is a real phenomenon. I guess, I'm actually curious in this open discussion is how many times you have to operate for whiplash injury, and anything more serious there.
No, for whiplash injury, really never, unless they have associated with the whiplash injury, like a traumatic disc herniation, for example, or, which is not that uncommon, that patients have underlying cervical stenosis. So they have spinal cord compression from cervical. Sometimes it's congenital, or it develops slowly over time. they have underlying cervical stenosis, which they didn't know about, and then they have a whiplash injury, and then they develop a central cord syndrome, meaning I had somebody just recently in a taxi, in a cab injury, in a cab accident, and who, had this and developed severe weakness in his arms and his hands. And then sometimes we end up operating on those patients. Or bike, in Central Park, people fall off the bike. I had an actor, a very well-known actor who fell off the bike, wore a helmet, his head was fine, but he had a severe central cord syndrome, and we had to decompress and stabilize his neck, and he got function back. But these can be very severe if there's underlying pathology. But just a whiplash alone with nothing else really pushing on the nerves, there's no surgical indication.
I think there's some questions related to some of this muscle pathology, and Vince, I don't know if you have opinions on laxity in the neck and treatments that you've used for that.
Yeah, I don't come across patients who necessarily have laxity as the chief dysfunction. I think more often than not, it's inappropriate activation of different muscle groups. For instance, a lot of people have really tight sternocleidomastoids, but they have almost no activation of their deep cervical flexors. And certainly in the case of whiplash, what we see is that after these injuries, people develop these sort of maladaptive patterns where they just sort of lock down. Everything just sort of locks down. And so, with the appropriate medical diagnosis and then referral to an experienced physical therapist, the physical therapist can help them relax the more superficial flexors. It can really help them reactivate those deep cervical flexors, which can then relieve pain. With whiplash in general, I think the general kind of mantra here is less is more. Actually, it can be very tempting to throw the book at somebody who has whiplash, but as Dr. Mehta, as you mentioned, you kind of try to manage things and with a lot of reassurance, a lot of really conservative care, and working on the basics, range of motion, and those sort of strengthening exercises. As far as the laxity is concerned, if I see laxity, it's usually in the context of a more broad hypermobility syndrome, which is a whole nother topic. But you can see that.
All right, we got still a few things to cover. One question here is low back issues. Can that cause neck pain? In my experience, not that much, but the reverse is true though. I have a lot of patients who have cervical problems, cervical, disc herniation, spinal cord compression, and that can cause low back pain. And I've seen a lot of patients recover from their low back pain once we fixed the cervical spine. But let's move on. Let's talk about the fun stuff, the injections. So maybe just one or two sentences, Vince, about trigger point injections. What is it for? How do you do it? And what's the prognosis?
Sure. So as I sort of went over in some of my previous slides, muscle can cause pain and muscle can cause referred pain. Releasing the muscle by passing a needle through various spots, tender spots in the muscle, can help relieve some of that pain. The main ingredient here is the needle. It's the actual mechanical stimulation of the muscle. Often we will add some numbing medication to help relax the muscle, help bring blood flow and oxygen to the area. All
right. Let's move on. A cervical medial branch block. Maybe just two sentences. Neel, what's that? When do you do that, and what does that entail?
Yeah, this is a procedure that is focused on the thought that the joints of the spine, of the cervical spine, are arthritic, have arthritis. And can we utilize the sensory nerves, the nerves that detect pain of those joints? If we block those, can we test that theory? So we use small amounts, very finite and targeted approach of lidocaine, which would block that nerve. And hopefully you would have relief in a significant way to be able to confirm that diagnosis.
And then you can figure out if the pain is coming from the facet joints or if you have If you're not sure, maybe it's coming from the exiting, there are nerves coming out that are not shown here, but you can block those nerves as well. Is that true?
Yeah, so that would be a different procedure. You would do
right.
a selective nerve root block on what we would think may be attributed by either stenosis or disc herniation of one of the nerves. Those are the root nerves. These are more sensory small branch nerves. And then also part of this is to avoid numbing everything along the way as you're putting the needle in, and really just being focused on the specific target.
And then here,
yeah, so this is the follow-up to that. So let's say the diagnosis is confirmed, you get temporary relief from the nerve block that we just talked about on the medial branches. Then, those are short-lived. So this is using thermal energy. It's using heat through a specialized needle, and that can quiet those nerves down anywhere from 6 months to a year. Again, all minimally invasive, no cutting or anything being done here.
And then here, I know this is a more involved procedure, but still minimally invasive, correct?
Correct. So this is using technology that is sort of on the related to pacemakers, like in the heart, and using electrical energy to slow down the firing of pain nerves. So in chronic neck pain, there's been interest in treating that with spinal cord stimulation. There was a recent study that came out comparing spinal cord stimulation to traditional treatments, and it was quite favorable in those that had neck and arm pain. So again, this is sort of a newer area of interest.
All right. We've got a lot of comments about injections. Some patients here had those injections. There was a question about massage also. Maybe a few words. I would think that massages can be very beneficial in a lot of these pain syndromes. Maybe Vince, do you want to?
I would agree. I just wish the relief lasted longer. I'll be honest. I am a believer in active therapies. I'll be honest. And so anything that I can get, anything that causes the patient to take an active role in their own treatment, I am for, such as exercise, and especially something that involves strengthening a weakened segment. I think in the long term that leads to better relief than things like massage. But the reality is especially in a more, I wouldn't say just when there's an acute injury, but sort of just after that acute phase, it can be quite helpful to reduce pain, certainly. And the reality is if you send somebody to physical therapy, that a good amount of what the physical therapist will do is manual therapy. A lot of it is a lot of this hands-on stuff that's very akin to massage.
We haven't talked about acupuncture. Any thoughts about that?
My thought is it's part of a multidisciplinary treatment plan. We're still trying to understand the mechanism of how it works. It has very low risk, and I usually try at least 5 to 10 sessions to see if there's benefit.
Yeah, I totally agree with that. I think that the risk profile, the fact that it has very low risk, means that I recommend it to my patients frequently. There have been these large studies that look at other studies actually and correlate all of the findings together. And in general, we find that acupuncture, there's moderate evidence to show that one can get moderate relief of pain with using acupuncture.
Yeah, I've used it in patients post-operatively who had post-operative pain. And it has worked in some patients, it's worked really, really well. Now, my favorite topic is the last two topics, which are pillows and mattresses at night. Tons of questions from patients, surgery, no surgery. The question is always posture after that, especially when you're relaxing and resting. And I recently got one of those neck pillows, and I like those a lot. But do you agree? Do you talk to your patients about this? And why? What does a neck pillow do, if you believe in it, that's beneficial for your neck?
I'll let Vince take the first stab at that one.
Sure, sure. I mean, if you look at this pillow, right, what is it doing? It's mimicking the natural curvature of your spine. It's mimicking how your spine should lie in general. And so I emphasize that when I talk to my patients, I emphasize two things. One, your spine should be in a relatively neutral position. It should not be bent, it should not be cricked, it should not be flexed, it should not be extended, it should be in neutral. I don't believe you need a fancy pillow to do that. However, if you have trouble getting your neck into that position, you get a pillow, something like this.
So here you put your head here, obviously, and your feet are to the right. Is that correct? So what it does is it extends, it puts it in very, very slight, maybe extension. It supports your shoulders or the neck, and so you put your head a little bit back. Is that true?
That or in relative neutral, I would say.
Yeah, it's supporting both the upper and lower portion of the neck, which is ideal. Now, this is probably best for those that sleep on their back, which is one of the best positions to sleep in. As you turn on to one side, it's again, you just need to have that posture, being supported.
Yeah. What about sleeping in a fetal position? Is that beneficial for your neck or not?
And I'm one of those. I actually prefer that. And neutral is usually for me 2 pillows to keep my neck relatively straight.
I think all of these questions, what makes what we do such an art is that everybody has slightly different pathology in the neck. Everybody has a slightly different pattern of wear and tear in their neck. Everybody needs something a little different. Sometimes I like to sort of empower my patients and say, listen to your body, listen to what it's telling you. Your body will tell you the right position to be in. And listening to that goes a long way.
All right. And now finally, before we go home, have a martini and then go to rest. What mattress? What do you tell patients? Hard mattress, soft, one of those absorbable mattresses. What do you recommend for back and for neck?
I go simple. I go with support. We just moved into a new house, had to buy 4 mattresses at the same time. Basically, each one we tried out. We really made sure we tried out. You lay perfectly onto the mattress, get your feet up on there. You look for, are you completely sinking in? Is there some support there? Same for your back end, for your neck. You sort of feel all the pressure points being areas of support.
So that tells me that, so you're saying more like a little bit on the harder side, the mattress.
Yeah, I guess it's just a little bit of the Goldilocks principle. Too hard also is not as comfortable, and too soft where you're just sinking in is also problematic. Right. So there's a happy medium for each person.
And Linda says you should try it in the store. Does that really work? I mean,
Yeah, what I was alluding to is you really got to get your feet on there, and don't be afraid to lay on it for 10 to 30 minutes.
I would fall asleep.
Mattresses have lifespans to them, so don't be afraid to upgrade and get a new one if it's been a while.
I find in our practices here, we're constantly trying to fight dogma in a way, and the sort of the dogma is that a stiff mattress or a hard mattress is better for one's back and maybe one's neck. But believe it or not, there's actually a scientific study on it. If you go on to PubMed, there is an actual study on it. And at the end of the day, what was recommended was a moderately stiff mattress. Lo and behold, it's exactly what you said. It's the Goldilocks principle. It's something that's just right, not too hard, not too soft, somewhere in between.
So at the end of the day, it's really common sense, I guess. As we find out every day in our practices, a lot of questions are really common sense. And I think we're getting towards the end now, or we actually are at the end, 45 minutes. And are there any concluding comments, remarks, any questions that we have missed here, Neel or Vince? Can you see anything?
My thought is that there's a number of treatments out there. You don't need all of them. it's really good to come to a center like this where there's a multiple offerings. You know, a couple of things we didn't talk about are broader muscle injections where you inject the entire muscle rather than focus spots. Even we've introduced laser therapy to try to stimulate muscle healing. And, you know, again, it's a really the diagnosis and systematic way of treatment.
All right. Vince, any final words?
I couldn't agree more. I'm really proud of the team approach that we have here. Everybody has their own little niche, and when we come together, we can all add to the puzzle and try and bring something to the table. You know, I will say that if you're having neck pain, a lot of what we do is education and sort of telling you about what is a serious symptom and what is a more common, less serious symptom. And so when you come in to see us, that's half of the game is being able to kind of partner with you to educate you about the status of your neck, what to look out for, and what to kind of take a deep breath and sort of live with for a bit.
All right, great. So Vince, Dr. Miccio sees patients at Methodist Hospital in Brooklyn, which is really now ramping up the spine program with on all levels, which is great. Neel, obviously you see patients here at the Center for Comprehensive Spine Care and a few other locations in Manhattan. Anybody, any questions, send us an email. If you want to see us in person, call the number or send an email. It's always great to do this. I want to thank
And
Roseanne.
video visits. Don't forget the video.
And video telemedicine. Yeah. Thank you for, Roseanne, Tatiana, for putting this all together, and we'll see you again in 2 weeks. Does anybody know what the topic is in 2 weeks?
I believe it's you and Dr. Rue, from what I remember.
That'll be a battle. Orthopedic versus neurosurgical. How should you make that decision? It'll be explosive. Now, we had Dr. Rue join us, a number of months ago. He's an orthopedic spine surgeon. All the other spine surgeons are neurosurgical, and it's a very, very important thing because patients really are confused and they want to know. So I'm looking forward to that. All right.
Have a good night, everybody.
Good night. Bye-bye.
Thank you, everyone.